So this is another or the last lecture in this StrokeEd series of lectures, and then we'll run another series of lectures in October, November this year. So I'd like to say a big welcome to everybody. We have lots of people from all over the world, basically, joining us here tonight. And we have Daniel Treacy, which we're absolutely thrilled that Daniel could join us to talk about balance. I'm going to start with an acknowledgement of country. So I'd like to begin by acknowledging the country that I'm on is country of the Gadigal and Wongal people, and I'd like to pay my respects to all elders, past, present, and future, and extend that respect to any Aboriginal or Torres Strait Islander people that are joining us here today.
And I'm on the land of the Bidjigal peoples, and very much would like to, similar to Simone, pay my respect to any elders, and really thank them for all the care that they provide over our land for many, 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 many years.
Thank you, Daniel. So I'm Simone Dorsch from StrokeEd, and we've invited Daniel to speak to us tonight because we are very aware of the amazing research he's been doing in the area of balance training. So I'd like to say an enormous thank you to Daniel for sharing his expertise and knowledge with us, and hand over to you, Daniel. Oh, sorry, just hang on for 2 seconds there. Just to a bit of Zoom etiquette for the Zoom webinar. If you have any questions for Daniel, please use the Q&A rather than the chat function and put your questions in the Q&A. Daniel's planning on delivering his lecture and then answering questions at the end of his lecture. So handing over to you now, Daniel.
Thanks very much, Simone. And yeah, and as Simone said, I'm Daniel Treacy. So my current role is as a physiotherapy advisor for the District of South East Sydney Local Health District, which is a large district within New South Wales Health. But previously, I was a clinician working within the aged care and rehabilitation setting. I've recently completed my PhD, and one of the areas I did have a bit of focus on was balance, and so very keen to share some of the literature out there. And I guess when we go through this, it's very much highlighting some of the literature, what's out there, but also getting you to have a think around what it actually means and also how accurate it is for when authors do make suggestions. And then we'll tie back towards the end around how you can make some groups effective, particularly when you're looking at implementing and challenging balance. So I'm just going to share my screen and just confirming that that's okay, Simone. Yep, excellent. All right, so I'm going to get started now. Thank you for that. So I'm going to start off talking a little bit around falls prevention. Now, we'll go back to a systematic review that was published in the B&J a couple of years ago. And this was actually taken from some of the review that was done in the Cochrane review, and had a bit more of a detailed look into, I guess, how the role of falls prevention in exercises. The inclusion for this systematic review was randomised controlled trials that evaluated the effects of any forms of exercise as a single intervention on falls in people aged 60 plus years and those living in the community. Now, if we just firstly look at that top line as a heading, and what we can see is overall we can see that there was 59 RCTs and high-grade evidence for the effectiveness of falls prevention, with a treatment effect of a 23% reduction in falls, which is really, that's really promising. We know evidence works, we know there's high-grade evidence, and we know it does have a good reduction in falls. However, if we go through the different types of exercises, we can actually see there is a difference in the effectiveness. So while things such as, balance and functional exercises, Tai Chi, and a combination of exercises that does include balance and gait exercises are effective for reducing falls, we can't necessarily be sure, or there's potentially a chance that it's not working for things like resistance exercise, maybe dance, and also just general physical activity. So this is really important when we're thinking around prescribing exercises. Back in 2011, Treacy Howe completed this Cochrane review looking at the effect of exercise for improving balance. Within this, they identified 94 studies, and to help understand the impact of the team divided exercises into 8 different categories. And so the ones they looked at were gait, balance, and coordination exercises, which we had 19 studies, strengthening exercises, 3D, which they include things like Tai Chi, dance, yoga, which I think are very similar in principle to balance and coordination exercises. They broke down general physical activities into both walking and cycling as an example. They had computerized balance training, which uses visual feedback, which I think now we'd probably call virtual reality training. They looked at vibration platforms and also multiple exercises that particularly included balance, but would include a combination of other exercises as well. Then in terms of outcomes, they had 6 primary outcomes. So they looked at to measure balance. So timed up and go, standing on one leg for long as possible with eyes open, similarly with eyes closed, walking speed, Berg balance, and then looking at adverse events associated with the exercise intervention. And I guess probably those first 4, I guess they were arguing are forms of measurement of balance. But it's probably particularly thinking, I think, some of them, there's probably other factors that are also going to influence those outcomes of tests. So you can make changes to other areas and perhaps without not necessarily balance that might result in improvement in these outcomes. So I guess in terms of hierarchy of evidence, when I've looked at what I'm presenting next, I've sort of judged the Berg balance scale to be probably the highest hierarchy of evidence for that outcome, and the next one to be the standing on one leg. And so this is a bit of a forest plot of outcomes from the systematic review, and it's broken down into the different exercise components. And these are for where our Berg balance was a scale, outcome scale. So what we can see is not all exercise types did use a Berg balance. So we've just identified that those that did. I guess a quick introduction around a forest plot. So you've got that line down the middle, which is, I guess, that idea of no change. For this example, where we've got favours exercise, if that diamond down the bottom is completely on the right-hand side, you know that there's statistically significant effects towards exercise. Similarly, if it's on the left-hand side, you've got that statistically significant evidence that it doesn't favour exercise, but rather favours a control. And if you've got examples that go across the line, you haven't necessarily got the evidence of the effectiveness. So it doesn't necessarily say it's not effective, but we haven't got any evidence to say it is effective. So I guess from a high level, if we just look at, gait balance, Tai Chi and dance and yoga, as well as those multiple exercise types, particularly remember focusing these do include balance, we can actually see improvements in all these. So statistically significant improvements. If we're probably looking at that clinically significant improvement, it's really probably gait, balance, and coordination exercises that we're particularly seeing the difference. What we probably do need to particularly highlight, though, is that if we're looking at strengthening exercises, we actually see that there isn't evidence of the effectiveness of that. And so that's probably something I just want you to particularly think about when we actually start to look at some of the other evidence as we go forward. This is the same Cochrane review, and this time they use the standing balance as the measure, single leg balance. And once again, I think there's probably multiple factors that do influence that. I think what we can see is that we can see that improvement in gait and balance, some improvement in strength, Tai Chi or yoga, but not necessarily that benefit we can't necessarily sure around that benefit around general physical activity and multiple exercise types. So I think going forward, I think if we're using this as a bit of an idea of what is effective, I think really that idea of that gait, balance, coordination exercises, as well as Tai Chi and yoga, are sort of the really key exercises that are really going to improve someone's balance. And once again, I'd flag that a lot of the principles around Tai Chi and yoga are things that we'll probably see when we discuss balance a bit more as well. This is work that Kathy Sherrington did on her systematic review a few years ago. And so this was, I guess, the carryover of, this is also similarly work further analysed from the Cochrane review they did. And what they did is to actually look at how various components of exercises made a difference in terms of the effect on the falls. And what we can see is that when you actually just had exercises that purely looked at, the highly challenging balance, we saw, that a good effect of falls. So that went from, 0.79, so around a 21% effect. For studies that had at least 3 hours per week of intervention, we saw that effect of 0.3. So that's rather good as well. So 30%, sorry, not 0.3, 30%. When you looked at studies that didn't have either highly challenging balance training or 3 hours, you actually got, although you got some effect, it was quite small compared to exercise programs that did have that. So when we're looking at falls reduction, particularly having that highly challenging balance training, as well as that 3 hours per week of intervention, really was shown to have a really positive effect. And so when talking around highly challenging balance components, the key things that we are talking around is that idea of reducing the base of support. So e.g. things such as, standing with 2 legs close together, standing with 1 foot directly in front of the other, or potentially standing on 1 leg. When talking around moving center of gravity, we're talking around that idea of controlling the body position while standing. So this could be something like, reaching towards an object, transferring body weight from 1 leg to another, stepping up onto a higher surface. And then finally, that idea of standing without the need of upper arms for support. Or if this is not possible, then aim to reduce reliance on the upper limb. So e.g., holding onto a surface with 1 hand rather than 2 hands, or decrease that support to 1 finger rather than a whole hand. So I guess that's a very good overview of the balance training, but there's probably other things that we want to know when we're trying to work out, what should we be prescribing for our patients? And so I guess the first thing is, what does the effect of location, and does that actually matter in terms of how we prescribe our care? And so this systematic review and meta-analysis, which was published last year in the Journal of Physiotherapy, compared the outcomes of home-based programs to equivalent doses of centre-based exercises in a stroke population. So this included both acute and chronic stroke patients. And what they did is they found 4 trials with 369 participants. And if we look at the results that compared the Berg Balance Scale, we really see no difference for those receiving the home-based intervention compared to, which is noted as experimental, or those that received the centre-based intervention, which here is noted as a control, immediately after the intervention. I think just quickly note that not all the interventions included balance, but they did include a variety of non-balance exercises, but the exercises were matched. And then a further period analysis was performed for following the intervention period. So what they did is that first one was just immediately after the intervention stopped, whereas this analysis was performed down the track. So this varied between 6 weeks and 6 months, but once again found very similar results for both home-based and centre-based programs. So once again, highlighting that they were equivalent dosages of intervention. Now, this systematic review and meta-analysis, which was led by Alison Flynn, looked at the effect of home-based prescribed exercises on balance-related activities in people with Parkinson's disease. Now, the first forest plot compared home-based interventions for people with Parkinson's disease, with the comparison being usual care or no care. And so I guess highlighting that, probably not unexpectedly, when we are doing that home-based exercises, which did include balance, we saw a statistically significant difference in the standardized mean for those people who received the home-based therapy. So, but once again, this was comparing to those who might not receive any therapy. However, if we're thinking of, applying balance training, this is probably a more helpful in terms of the analysis, because in this case, they compared home-based exercises with, once again, an equivalent centre-based program. Also, what's really helpful is both of these studies programs included a majority of balance exercises, with the programs consisting of 92 to 100% of the program being balance exercises. So what we see is with 3 trials, 176 subjects that meet this criteria, we can see there's no difference in the results depending on the delivery of intervention. So we can be confident when we're delivering balance training, whether it's centre-based or whether it's home-based, if the intervention amount is the same, we're going to get similar amounts, which is really, I think, quite promising, and it sort of can help us guide in terms of where the intervention can be. Just the next question is, does dose matter? And that's probably something that's really particularly important when we're looking at prescribing our programs or delivering our programs. So I guess going back to Alison Flynn's systematic review, and they did a separate analysis for those interventions that received a high dose of balance training. And they noted this to be a minimum of 150 minutes per week for at least 6 weeks, as well as looking at an analysis of studies that didn't provide high dosage. Now, when they looked at the outcomes for those that did provide a high dosage of balance training, they found 7 studies and 964 participants. And what we can see is we get a statistically significant difference when we compare this to usual care or placebo. So what we're confident here is that an exercise program delivered to greater than 150 minutes per week compared to nothing is going to result in improvements in balance. The next analysis down the next part looked at those interventions that actually had doses less than 150 minutes per week. And what we can see, and they had around 4 studies, 246 participants, and we actually see there's no difference. We can't actually see a difference between those people who did receive it to those people who received nothing. And so once again, I think this is a particularly good and relevant study because it did include, a high level percentage of balance training. High doses were prescribed, yet it really is only, where the high doses are prescribed that we see the effect, not the low doses. This study was published in the Journal of Aging and Physical Activity and looked at the dose-response relationship of balance training in physically active older adults. And I guess just as a brief rundown, the exercise included Tai Chi, balance and mobility exercises. And they had a total of 60 participants, which were divided into 3 groups. Now, the 3 different groups, so one group received 3 lots of 20 minutes, another received 1 program within the week, so 1 lot of 20 minutes, and the third was a control. What I've done in the box is I've just noted the changes that they made over their initial outcomes, but really important to note that none of the changes were statistically significant. Now, if we're really critically analysing this study, although there is probably, an increase between control and the middle group, as well as that middle group and the top group, we really shouldn't be expecting a significant difference in change with this dosage anyhow. So I think what we can probably draw out of it is, although there potentially were some changes, the reason why it wasn't statistically significant is the level of dosage really isn't satisfactory to make that change. This systematic review looked at, once again, the overall dose relationship regarding the total duration of balance training per week, and just, I guess, looked at showing it off in a different way. And what we can see is a difference in outcomes. We're potentially seeing perhaps once we're at 60 minutes per week, but we're really probably starting to see that clinically significant difference around 90 minutes per week of balance training. Potentially drops down a little bit around that, 120 to 151 minutes, but generally a standardized mean difference of 1 is a relatively good difference. So, I think if we're seeing that difference there, I think we can be pretty confident for this healthy older population that, greater than 91 minutes or greater than 90 minutes is what we probably should be prescribing in terms of intervention dosage. The last one, even, there's lots of evidence around that 151 to 180 minutes. So we can sort of be also confident we see a change there. And although there weren't necessarily many studies at the 181 to 210 amount, we once again can see a good outcome. So, probably 90 is at minimum, but we're probably wanting to increase those levels. This same one actually then looked at the overall dose relationship regarding the total number of training sessions. So generally what we're seeing is that a higher number of sessions will be resulting in a greater change. Though acknowledging, there's that outlier around 26 to 30, though it generally more sessions is better. And probably if we're looking at that finding, probably that 36 to 40 session is where we're getting our best outcome. And so probably really encouraging, multiple sessions. So if we are looking at perhaps 3 sessions a week, programs probably over around at least 12 weeks is probably the main thing. But I guess in principle, having more programs or having that longer duration really seems to be the key thing. The next question, I guess, is important to think around. And often when we look at balance training, one of our concerns is around people falling if we are doing that highly challenging balance program, and concerned of perhaps having more adverse events. So where does supervision fit in? So this was an analysis that Flynn did, looking at results separated for home-based exercise programs that were 100% supervised. So for example, this would be someone coming to someone's home and doing the program with them, versus minimal supervision, which they sort of classified as less than 33%. So an example of this would be going to a patient's home, setting them up with the exercise, maybe walking them through doing it, but then expecting them to do that by themselves. And so as we can see by the forest plot, the outcomes for those programs that were 100% supervised doesn't necessarily show any difference compared to the control. However, it's important to note that the 2 studies in which the analysis didn't provide, two studies here, didn't actually provide balance training intervention. So they're not actually providing a evidence-based evidence-based program to improve balance. So we can't necessarily be sure it's a supervision factor that's causing that. Perhaps it's just the actual exercise type that's resulting in that. What we do see is when we look at that minimal supervision group, we actually do see a statistically significant change. And most of these exercise programs did include balance. So we can say that we can see changes with interventions with minimal supervision. However, we just can't draw any conclusion in regards to fully supervised programs. This systematic review looked at compared studies that had looked at the effects of supervised versus unsupervised training once again. And in these cases, training could be balance training, combination of balance and resistance, or resistance alone. I think one of the big things I will highlight with this systematic review is it did include programs that didn't have that. When they compared them, they didn't compare them to balance training. And sometimes the supervised program was quite different to the unsupervised program. So for example, this one in the middle, this Carrigan one, that you can sort of see does have quite a positive effect. In the supervised group, they did exergaming focusing on balanced, while the unsupervised group did a predominantly around that resistance training. They did a bit of balance training, but predominantly resistance training. And so if we're thinking of that, what exercises are most effective for improving balance, we do know that balance training is more effective than resistance training. And so we're naturally going to see a difference just purely by that exercise type, as opposed to whether it's supervised or unsupervised. So although I guess this would suggest that there is more evidence for supervised programs. I think we just have to be careful in terms of making that assumption to balance training, which is effective, because there's not necessarily that true comparison here. So I think in terms of supervision for this one, I think probably the results are a bit questionable. I guess also staying on that theme of safety and worrying about, I guess, patients and falling is that idea of whether aquatic-based therapy is potentially an option. So you're potentially less likely to fall if you are doing aquatic-based injury, or maybe not less likely to fall, but you're probably less likely to have an injury. And so this systematic review looked at studies that compared land-based exercises versus aquatic exercises. They had balances and outcome. They found 11 studies, included 10 of these in a meta-analysis, with the inclusion criteria being greater than 65 years. We can see there was 3 separate subgroups. So these were each looking at a different outcome. So we had that dynamic steady state balance, proactive balance, and also balance tests. What you can see is with all these forest plots, we can see that the 95% confidence interval crosses 0. So the authors concluded from this that you'd see comparable changes in both land-based and aquatic-based therapy for balance outcomes. But once again, putting our thinking hats on and really thinking around what the evidence is, the thing to particularly flag here is that many of these land-based interventions weren't balance training, and some were just strength and range of movement training. So when they were comparing that aquatic-based therapy to something that's not going to improve balance, we're not necessarily going to expect to see changes. So what I did is actually pulled out those studies that didn't include balance training. And so what we're seeing here is an analysis that purely looked at where land-based exercises were primarily balanced and compare them to aquatic exercises. And what we can see that is when we actually purely look at balance training, at land-based balance training, we can actually see there is a difference when we compare it to aquatic-based therapy. So we can be sure when we're actually looking at implementing evidence-based standing balance training that that is more effective on land-based than aquatic. So I'm going to talk a little bit around reactive stepping training, or what's sometimes called perturbation-based balance training. And this is what uses, I guess, a task-specific approach to balance interventions by repeatedly exposing an individual to mechanical perturbations. So these interventions can then make the balance experiences, such as daily slips and trips, to try to really enhance that capacity to regain stability as well as prevent falls. Now, it's proposed to enhance the sensory system, so including tactile, perceptive, visual, and vestibular sensations, to detect that postural slip and be able to respond to that more effectively. Now, this has been quite effective in improving falls. So if we have a look at these systematic reviews, so that top one was looking at the number of falls, and we can see there is that strong reduction in terms of the number of falls. And similarly, delivering this type of intervention, we also see a strong outcome in terms of decreasing the proportion of fallers. Now, if we actually start to then look at some of the balance training, we can sort of see that perhaps there maybe is it doesn't necessarily seem to be that strong change. Maybe there is, perhaps, if we look at that top one, but overall, it's probably it's probably firstly worth flagging that a lot of these studies that they're comparing to were maybe comparing to interventions that didn't necessarily have balance training, or perhaps were controls. So if we actually just have a look at these 3 ones that were highlighted, what we can see is this is where reactive stepping training or perturbation exercises were compared to balance training programs, or programs that included balance training approach. And so what we can actually see is very similar results. So if we just looked at those forest plots for those areas, we actually don't see much of a difference. So we're not saying that perturbation-based training doesn't improve balance, but we can't necessarily say it's more effective in improving balance than balance training. The next one is just virtual reality, and particularly when I'm talking around virtual reality, I'm particularly talking around balance training virtual reality. And so when we talked initially around some of those highly challenging balance principles, we talked around things like having narrow bases of support, shifting your weight, sort of reaching, not using your hands for balance. And a lot of research that's been done, and these are a couple of examples of some of the technology people have been using, and particularly some of the technology that's used in these next couple of slides, is using technology to try to challenge people's balance in these ways. So this is a systematic review, once again, looking at the effect of virtual reality balance training on the stroke population. This is a recent publication. I will just firstly call out that down the bottom in terms of where VR-based balance training in the control group, that actually should be reversed. So there's a mistake done in the paper, so that should be reversed. But what they did see is when you looked at that chronic population, they found 14 randomized controlled trials, a reasonable number, and that the patients who did receive virtual reality had marked improvements in the Berg balance scale. Once again, I'll flag that this isn't necessarily comparing to balance training. This is comparing to control groups, so potentially people receiving usual or no care. But it's good to highlight that, using a balance-based approach, using virtual reality, we do still see that improvement in balance. Once again, this idea of adding VR in to replace some of the therapies. So for, once again, stroke patients, so this wasn't totally virtual reality balance training, but they added some components in. And what they did see is, once again, an improvement. But once again, flagging, we're not necessarily like for like. So the control group in these, or standard therapy, might have received things like strength training or range of movement training. So once again, we're seeing that virtual reality balance training is effective, but we're not necessarily saying it's more effective than balance training. So those were some examples for the stroke population. This one looked at the effect of virtual reality balance training on Parkinson's disease, and once again compared it to usual care or no care. This program ran for 6 weeks, 40-minute session 3 times a week, and used the Berg balance scale. And once again, we didn't compare, the study didn't compare to like programs, so not all treatments were equal. But once again, we get that idea that virtual reality balance training is effective in a Parkinson's population, but we just know it's more effective than sort of standard or no care. We don't necessarily know it's more effective than balance training by itself. And this is another example that looked at the virtual reality balance training. It did the strength of this is it did compare it to other physical interventions. Once again, we did see an improvement, but we also need to note that some of the control interventions didn't include balance training. So if we're looking at some of the particular ones, sort of that Lee study, the Ribber study, which also had positive outcomes, and the Gandolfi study, all didn't include balance training in the control group. So I think promising, we are seeing those positive results for VR balance training in a different population. And this one, I think, sort of tells a bit of a story in that this was a systematic review, once again, looking virtual reality training, compared reality balance training against a similar balance training program. So they were fairly similar. So I think we've sort of been talking around how some of the challenges were that we're not comparing like for like. The good thing was this one did. But we see similar results. So, so when we're comparing actually standard balance training, we're not necessarily seeing significant more improvements compared to balance training done with virtual reality. I'll talk a little bit around dual task training because that often is talked about or used as a balance intervention. This systematic review with stroke patients compared to strength training or single task training. So once again, we see some sort of, in terms of the dual task, it did involve some balance training, but we're comparing it here to something that's not necessarily evidence-based or something that's not necessarily expected to improve balance. I'm sorry, and here I guess just highlighting. So actually, this one was just looking at control ones in terms of no actual intervention. This one, once again, for the stroke population, a different systematic review, but similarly seeing when we're looking at a control group, not really seeing a positive result, but doing balance training, whether it's with dual task or not, we're probably going to expect to see a difference anyhow. And then this one, once again, looked at the group included no training, also strength training. And so I guess, although we saw a really positive effect, and if we particularly look at that Forsberg study up the top, that this one actually compared it to no training at all. And once again, another example in terms of with Parkinson's disease, and we look at that good or bad, but we see a positive result for doing dual task training, which would involve balance. But when we go back and actually compare it to nothing, we do see a difference. And so we're not actually sure if we compared this to balance training, whether we'd see a difference. I guess the other thing is, and I think we notice our population's becoming more and more frail, and what are the effects actually on frail individuals? And I think sometimes we often treat them as a bit different, that we feel that perhaps frail individuals, might not have that ability to change, or there's a real focus that strength training might be the key intervention that frail individuals do need. So there's not necessarily a lot of evidence out there, but there's a recent systematic review that I was involved with, which got published in the Cochrane Review, that looked at the effect of mobility training on a frail population. And one of the strengths of the study, of the systematic review, is it really focused on frail population. So people had to justify that the population was frail. What I actually did is then went into some of the analysis and actually looked at those studies that measured balance as an outcome, and actually took that outcome separately and used it as an analysis to do. And so for a frail population, what we can see is for those people who did receive training, and training had to include balance and mobility training, it could have included others, but I guess I guess the headline here is we're saying that studies that for frail population, that studies that do include mobility and balance training, as well as potentially strength training, we do have that ability to improve someone's balance. So it's good to also know that we also see similar improvements with balance training for people for a frail population. So if we have a bit of a summary of the things that we've talked about today, firstly, that we do know that balance training is effective, and the key factors to making it effective is that idea of reducing the base of support, having that nice controlled movement of the center of gravity, and reducing the need for upper limb support. In terms of where that intervention takes place, there really is at this stage, the evidence says there's no difference. So whether that's center-based or whether it's provided within a person's home, they appear to be equally effective. We do know that improvements can be made with minimally supervised programs. However, we don't necessarily know if greater benefits will be received with higher levels of supervision. But I guess it's promising to know that, minimally supervised programs, which quite often mean, not as much intervention needed to be provided by therapists, so more achievable in the community, are effective. We do know that we want land-based rather than aquatic-based. And I guess I've put down greater than 91 minutes in terms of per week of the intervention. But I think, we probably are looking a bit higher than that. So I think really trying to encourage higher dosages than that. And I guess finally highlighting that balance training using virtual reality is effective, but it's not we don't necessarily know if it's more effective than providing balance training through other means. So I guess in terms of how do we then provide it, if we're looking at something like, providing it in circuit classes, what's an effective way, or what are some of the ways that we can, effectively do balancing classes? And I'll take you back to a systematic review, a study that we led, it was a few years ago, but looking at implementing some of the principles that we talked around here, but also some other principles I'll go to at the end around the standing balance circuit classes. And when we designed the stations, all the stations were really designed to challenge people's balance with minimal hand support. Each station lasts 6 minutes, and patients perform 6 of the 7 stations. In terms of supervision, 2 to 8, which was used, and trained for 3 hours, 3 times a week. Just in terms of the amount of exercise or repetitions people did, and you can see there is quite a high number. So averaging 427 over a day or each session, and total intervention period being around a bit over 2,000 over a 2-week period. In terms of the outcomes, and I'll just particularly highlight, there's some really promising outcomes in terms of mobility and function, but just particularly highlighting around the standing balance as a measure. And what we can see is the groups were quite similar at baseline, but 2 weeks, we do see that big difference in terms of statistically significant difference as well. What was really promising is when we actually, just with the 2-week intervention, is when we then left it, looked down the track 3 months, we actually we saw that difference was maintained. So really promisingly that this balance effect could actually have a lasting effect. And so some of the key principles that we did talk around was actually around the needing to have that narrow base of support, minimizing arms, and also using controlled movements. And so when we also designed it, we needed to make sure there were particularly some enablers that really allowed us to do that. And a lot of that was stuff that was things that we actually looked at the evidence in terms of those circuit classes and those groups that were most effective at improving balance or most effective at having that high compliance. And we use them as enablers in terms of how we were designing the program. And so the first thing was how you design your environment to be both safe and challenging. That's a bit of a big overview of what the exercises look like, or how it's particularly run when it's at full ball as such. But in terms of, I guess, how you look at setting up some of those individual ones, is that idea of how do you keep people safe while doing it challenging? And so if we look at, examples going from left to right, once again, the person's got that ability to reach out if they need to balance themselves while we're being challenged. But there is, in pretty much most directions, that ability to catch themselves. So if they are doing something challenging, there's a wall, there's a table, or there's a plinth that they can then use to regain and capture to regain steadiness. Similarly, we see that picture in the middle, set up so the person can do a reaching activity, so challenging, but still that safetiness in terms of the environment. And once again, that third example where we're practicing, a simple weight shift movement, there's that ability for the person to perform it safely, but where they're most likely to be challenged, there's also that environmental cues or support to stop them. So if they do become unsteady, they'll be able to be caught effectively or be able to catch themselves effectively. The other thing that we did is what we found was that peer learning was a really effective model in terms of, I guess, that engagement, that learning experience, but also keeping up that high compliance. And we sort of thought, how do you get that going? And so one of the things that we did is, rather than having a traditional group that might start, every month or every 6 weeks or something like that, we'd actually have an ongoing group, so that you potentially would have people in the group who might have been doing it for, a week or 2 weeks. And then coming into the group would be people who are quite new, who would be at their first session. So they would be able to see people who perhaps would be doing this class, doing these exercises for multiple sessions, and be able to actually learn from them. So learn some of the strategies, but also get that idea of that compliance, and also see that engaging environment, that there's someone similar to them doing the task. And although they might be challenging to begin with, that they feel that they can do it. So if they're seeing that peer learning, that was something that we found to be really particularly effective as well. The third enabler that we found, and when we were looking, there's quite a few good studies that had done something similar, but having station principles, I guess I'd describe it as having station principles with different levels. So, for example, in our study, we had 7 different stations, which had different exercises. But at each exercise station, there were different levels that patients could progress to. So if someone found it very hard to do a particular exercise, it wasn't that we would change the exercise. It was just the extent to which they would do it. The extent that was challenging would be minimised, or would be directed towards their level. For example, when we did it, we had 3 different levels, but also noting that there's other studies that tend to have sort of anywhere between 3 to 5 different levels. So we sort of thought that was a really important principle, to be able to have patients still do those exercises, still feel that they belong to the group, still see their peer perhaps doing those similar exercises, but have it at something that potentially suits them in terms of the challenging level and is appropriate for them as well. I haven't put it there, but I guess I also talked a little bit around that supervision level. I know I talked around it a bit before in terms of some of the evidence. And although we didn't necessarily find that there was evidence in terms of the number of people to support it, we did generally find that, having that group-based or having that less supervision was probably something to particularly encourage. And it probably did result in greater compliance and greater amount of exercises as well. So I'm going to stop there and just hand over to Simone to see if there's any questions or anything that people would like to ask following this talk. Also,
thank you.
Sharing if you like.
Thank you very much, Daniel. That's an amazing overview of the literature. Very, very fantastic. Thank you very much. We do have a few questions that I'll bring up. So the first question that we have here is from Alicia, and she's asking whether the home-based exercise in the work that you're talking about, comparing home-based to centre-based, do you know whether the home-based was provided by physios or self-directed or from some other caregiver?
Yeah, really great question. They were provided by physiotherapists. And in terms of how they were often provided, is that it would be potentially a home visit that would go out there. They would prescribe the exercises. They would work with the participant or the on how they could do the exercises. And so there's a particularly good, some good work that Kathy Sherrington is has been leading now around really engaging with is that idea of going out to the person's community, setting them up with the exercises, and I guess having those principles, but working with the participant around where they can do it. So, while someone might have a really good dining table or something like that, someone might not. And so really working with that individual around where they can do those exercises safely and effectively.
Thank you. The next question is from our old buddy, Julie Nugent. So hello out there.
Hey, Julie.
And Julie's, well, I think she's really asking you to theorize as to why water-based exercise is not effective compared to land-based. Is it because of the water supporting the body?
Yeah, really great question. And I think it's very much around that. If we're thinking of what some of those principles are, is that idea of not holding on, because we know that sort of gives that additional benefit. We are trying to really push our balance to those far extremes. And one of the things is, I guess, if we're on land and we start to fall, we really need to have the active response to, if we're thinking of someone maybe leaning forward, where our dorsiflexors, our plantar flexors are going to respond, and actually take that proactive response to actually push us back. Or if we're thinking of moving sideways to sideways, our muscles are going to have to respond, and have to respond quite quickly. And that's where we're getting the balance training. In the aquarobic setting, we don't actually have as quick a response, or need to implement that quicker response. If you theoretically fall, you're going to fall into the water and not necessarily do that damage. So it's not going to push you that much. And it's also not going to push you at that speed and, I guess, that velocity that you particularly need to activate your muscles. So I think that's probably where we're probably not seeing that change, why we're not seeing that change.
Yeah. So very much comes down to sort of the context specificity of we need to
absolutely
move quickly against gravity.
Yeah.
Yes. We have a question from Muragavel asking about literature on the efficacy of screening predictors of falls, like fear of falling or reduced confidence.
Yeah.
So is there any literature? My understanding is that there is some that indicates that reduced confidence or fear of falling does help to predict falls.
Yeah, there is, and there's definitely some good evidence out there. I think if we're looking at sort of that outpatient community setting, there is some evidence around that as well. I'm not sure if there's people around the inpatient aspect, but there's probably not as much evidence around there as well. And I guess there's education on falls prevent and how to get up. Around balance, and I think it doesn't necessarily have that. We're not necessarily seeing improvements in balance training from providing evidence of falls prevention strategies. So I think once again, we do need to actually do that balance training. So that, I guess that bottom part around education improving balance, not so much. We don't actually see that.
There's a couple of questions from Roz about stroke, particularly. And this first one is about is aquatic therapy more effective than home-based or clinic-based training programs? Are you familiar with the stroke literature around aquatic versus land-based, Daniel?
I'm not. I did know there was one study I saw that did look at that, and there didn't appear to be that study that I did find did compare it. Unfortunately, didn't compare it to an effective balance treatment, and actually, anyhow, didn't actually find an effect anyhow. So once again, I think although that systematic review that didn't necessarily look at for stroke specific, I think we go back to that, what's effective in terms of that task specificity, and that we probably really do need to focus on that land balance training. So not saying that perhaps there's other areas that hydrotherapy might be effective, but really if we're wanting to train that balance, it really does need to be land-based.
I can probably add to that just because I'm on the working party for standing balance for the stroke guidelines. And so we do review the evidence about balance training and stroke quite regularly on that. And that while there are some systematic reviews that indicate that aquatic therapy can make a difference to balance, we run into the same problem, is that the aquatic therapy is not being compared to proper balance exercises land-based. So where it is being shown to be effective, it's often because it's being compared to a placebo or a non-balance training intervention on the land. So I think so far we really don't have any convincing evidence that aquatic therapy is really helpful for improving balance in stroke survivors. The next question is also from Roz, and it's about I think it's really asking whether if Tai Chi is being used, whether it should be done in combination with physio.
Yeah, really good question. I think I think they've particularly shown that it's really focusing on the balance principles. I think maybe that while there's particular movements that people can do in terms of Tai Chi, in my understanding of some of the Tai Chi programs, as long as it's a Tai Chi program that particularly has that idea of that controlled movement in terms of narrowing your base support, not holding on, and that really controlled movement, there's not going to be, it's still providing that idea of highly challenging balance. And that's why we're seeing that's why you're seeing the improvements with Tai Chi. So I think although there's probably other components to it, I don't necessarily think we need to add in physio as well as Tai Chi. I think doing that, keeping those principles, challenging your balance, narrow base support and control movement is going to be effective whether it's physio or Tai Chi.
Yeah, yeah. There's a question from Murtag about frail populations and whether these sorts of whether more frail populations can still complete that greater than 90 minutes of exercise per week.
Yeah, really good question. And it was interesting. We did look at because there was a couple of studies that had some really promising outcomes and some that not so much. And when we did do an analysis, we thought perhaps an amount of dosage did impact, and it might partly be that we maybe didn't have enough numbers to run that, but we actually didn't see necessarily a difference in terms of the dosage for that frail population. So not necessarily haven't answered your question yet. Okay, but the next part is there was actually a really big range, and there was actually a reasonable amount of studies that could complete greater than 90 minutes as well. And a lot of these were either a combination of centre-based or home-based therapy. We did find that even with the frail-based populations, that those who did perhaps exercise programs at home, or those that did additional training at home, or that did it in group classes, just had just as good an effect as those that actually did it at the centre base or did it with good supervision. So I guess to summarise, to get back to your direct answer, yeah, a lot were able to do that and actually had programs that high or higher.
And I guess in some ways, when you think about it across a whole week, 90 minutes is not that much exercise, is it? When you think about the levels of physical activity that we should be doing.
Yeah.
Yeah. There's a question from Kwabina about levels of supervision and whether you have any evidence about the, I guess, relationships between amount of supervision and numbers of adverse events.
Yeah, really good question. And that was one of the things I was interested. So when I did look at those systematic reviews that reported supervision, although they didn't necessarily report an adverse effects, that's something I actually was interested in, and so actually went into. There was a bit of a mixture around whether they did report it, but looking at the numbers are actually fairly similar, and it's hard to know. Perhaps is it the way that it might be the way that they're documenting, it might not, but there actually didn't appear to be any difference in the number of adverse events for those studies that did compare supervised versus non-supervised programs.
I guess, is it worth adding that for your balanced circuit class that you ran in that inpatient setting with a very frail population of people and 2 therapists to 8 patients, that were there many adverse events in during that trial, Daniel?
No, and that's a really good question, good point. And that was a study that we did run, and although we had 162 patients in trial, we did run it for a lot longer as an ongoing group. And I don't know if we had any. We might, if we did have any over a couple of years, it probably would have been potentially 1 or 2. So they were really quite low numbers. And then I see one of the questions was around the minimal levels that patients needed to achieve, and it was I guess a bit of a grey one in terms of we just felt they needed to participate in the group with minimal supervision. But I guess to help maybe understand what that might mean is there actually are participants in there that actually didn't have, couldn't walk. So there are actually people who had no mobility at all. The particular participants who maybe could only stand for 5 to, maybe actually probably 30 seconds to begin with. So we're sort of what they had to do was reasonably low to begin with. And as Simone suggested, they were, really quite a frail and older population as well.
There's a very good question here from Anonymous here, asking about frail populations. When you were talking about strength/resistance training, is there a place for strength resistance training? For example, doing combination of balance and resistance training?
Yeah, that's an excellent question. I think it's really coming back to that patient-centered aspect approach of what we're trying to do and what we're trying to improve. So, and if we look at all in the evidence as well, so I guess also noting that, it would be great to, if we gave, patient balance exercise, resistance exercise, endurance exercises, if we give patients too much exercise, they're not going to do it. So I think firstly, we need to be wary about how much exercise that we do give them. I think it then comes back to what are we trying to improve? So for example, if we've got a frail individual who we're treating and they particularly got balance and mobility and falls issues, we need to really make sure that we focus those exercises on evidence that works for them. So, doing the balance training, doing mobility training, because we know they are effective. Whereas if someone perhaps, has balance issues, but also has some obvious strength issues and function issues, let's target it towards that. So I don't necessarily think it's a not having strength training in or only having strength training in. I think it's really coming back to what's the evidence for particular things that we want to train within a frail population and really trying to target our intervention at those people.
That's all the questions that we have.
Excellent.
So thank you very much, Daniel. That's been the most amazingly comprehensive overview of everything that has been kind of done about balance out there in the research. So thank you very much, and thank you to all our attendees, and thank you for your great questions that you contributed there.
No, thanks. Thanks for the invite. It's my pleasure.
There's some thank yous coming up now in the Q&A, Daniel. Okay, I'm going to